A single 3% discount mistake cost the United States health system $3 billion last year. Yet 30% of cost-effectiveness studies contain that fatal flaw, and 41% still use price data older than 5 years, despite 5.8% inflation. That error can raise your health insurance premium by dollars each month, push hospitals into cuts, and increase out-of-pocket drug costs for you and your family. Stick around. I'll reveal the 3 simple checks that prevent billion-dollar MI. Picture this: a single missing zero in a spreadsheet, a tiny oversight that silently adds up to $3 billion slipping through the cracks of our healthcare system. That's not a headline-grabbing scandal. It's the everyday reality of a modeling error that most of us never even see. Those billions don't stay on a balance sheet. They trickle down into the premiums you pay each month, the services hospitals have to cut, and the out-of-pocket drug costs that hit your family's budget. In other words, a tiny mistake in an economic model can become a real-world bill for every American. So how do we stop that cascade before it starts? I'm going to give you 3 simple, repeatable checks that catch the most common and most costly errors before they ever leave the spreadsheet. Master these, and you'll protect your organization, your patients, and your bottom line. The first check is the one that trips up 68% of senior economists when they look at junior analysts' work: the discount rate. Skipping it or applying it incorrectly inflates future benefits and costs, turning a sensible projection into a wildly misleading one. Let's unpack why the discount rate matters, how the mistake happens, and what you can do in seconds to get it right. Imagine a $150 million overpayment that vanished simply because a 3% discount rate never made it onto the spreadsheet. That's not a rare typo, it's a systemic flaw. Roughly 30% of United States cost-effectiveness analyzes skip discounting altogether, and when they do, total quality-adjusted life years balloon by 12 to 25%. In plain terms, an intervention that truly costs $85,000 per quality-adjusted life year can look like $68,000 per quality-adjusted life year, pushing it over the adoption line and draining budgets. Take the 2023 Midwest Telehealth Reimbursement Model. The state's analysts applied no discount to projected 5-year savings and used 2018 device prices. The result: quality-adjusted life years were overstated by 18%. The incremental cost-effectiveness ratio fell from $85,000 to $68,000 per quality-adjusted life year, and the Medicaid agency paid an extra $150 million. When they corrected the model, adding a uniform 3% discount to both costs and outcomes, updating costs to 2022 prices, and running a probabilistic sensitivity analysis, the ratio rebounded to $84,000 per quality-adjusted life year, and the contract was renegotiated, saving $120 million. A similar story unfolded with a CART therapy in 2022. The manufacturer's submission set the discount rate to 0 for long-term survival benefits, inflating lifetime quality-adjusted life years by 22% and making the therapy appear $20,000 per quality-adjusted life year cheaper than the $100,000 threshold. After a 3% discount was applied, the true ratio jumped to $150,000 per quality-adjusted life year, prompting the payer to replace full coverage with a risk-sharing agreement that limited exposure to $45 million instead of the projected $300 million. Even startup pitch decks fall prey to the same slip. An AI diagnostic tool claimed a 250% return on investment over 3 years by discounting only costs, not the projected revenue and health gains. Once a proper 3% discount was applied to outcomes, the return on investment fell to 55%, reshaping the financing round from $50 million to a realistic $12 million. Why does this happen? Many analysts conflate inflation with discounting. 2023 Healthcare Consumer Price Index ran at 5.8%, while the recommended discount rate stayed at 3%. Others assume a 0 discount makes a model look more attractive, forgetting that the same principle that makes patients overvalue immediate benefits also requires us to devalue future benefits in economic models. Experts agree it's the most common error. Dr. Michael Drummond warns that a missing discount rate inflates benefits and misleads decision-makers. Dr. Amy Finkelstein adds that a 10% error can flip a value-based contract from profit to loss. John Lee, chief financial officer of a major academic medical center, says his 3-step model audit checklist catches 85% of such MIB before they hit the bottom line. The fix is straightforward and takes seconds. First, set the base discount rate, 3% for United States analyses, or follow local guidance. Second, apply it uniformly to both costs and quality-adjusted life years using the same formula. Third, run a one-way sensitivity on the rate, typically 2 to 4%, and display the impact in a tornado diagram. Fourth, document the rate, the year of price data, and the inflation adjustment method in the methods table. And finally, run a quick audit checklist to confirm the discount is applied to costs, to outcomes, and that a sensitivity range is defined. Master these steps, and you'll eliminate a mistake that, on average, costs the health system $1.2 billion per error. But the discount rate isn't the only silent culprit. There's another hidden threat that often travels hand in hand with it, eroding your savings even further. Stay tuned, because we'll uncover that in the next segment. Now that you've secured the discount rate, let's explore how using out-of-date cost data can wipe out those savings in an instant. Here's the part that can erase all the savings you just built: out-of-date cost data. When you look at the evidence base, 41% of United States cost-effectiveness analyses still rely on price lists that are 5 years old or older. That isn't just a tidy statistic. It translates into a 30% understatement of true costs, because the Medical Consumer Price Index has been climbing at 5.8% annually, almost double the overall inflation rate. One real-world case illustrates the impact. A CART therapy model used a 2018 wholesale acquisition cost and reported an incremental cost-effectiveness ratio of $20,000 per quality-adjusted life year, well below the $150,000 threshold. The model was cited in a state budget proposal, inflating projected national spending by $3 billion before the error was corrected with the 2023 average sales price and a proper consumer price index adjustment. The pattern repeats across settings. A Midwest health system's telehealth cost savings model pulled a 2018 Chargemaster for a remote monitoring device, overstating savings by $45 million. A state Medicaid expansion plan relied on a 2017 pharmacy list that ignored the Inflation Reduction Act's drug price cuts, leaving a $1.1 billion shortfall. In each instance, the root cause was the same. The price year wasn't recorded, so no inflation adjustment was applied, and the model silently fed the payer billions of dollars in error. Experts agree this is a silent killer. Dr. Michael Drummond warns that outdated prices skew the incremental cost-effectiveness ratio just as much as a missing discount rate. The Government Accountability Office found that 27% of Medicare Advantage payment models used cost inputs older than 5 years, costing the Treasury $2.4 billion in 2022 alone. The fix is simple and repeatable. First, tag every cost input with its source year. Second, inflate or deflate that figure to your analysis year using the Medical Consumer Price Index or a drug-specific index. Third, document the adjusted cost in a version-controlled table and set a quarterly reminder to refresh the data. Automation tools, Google Sheets import XML for CMS fee schedules, or an application programming interface pull from the Red Book can handle the heavy lifting, while a quick unit test flags any price that's older than 6 months. But wait, there's a hidden twist most analysts miss: how the choice of comparator and perspective can amplify or cancel out these cost errors. We'll uncover that in the next segment. Now that you've learned how stale prices can wipe out your savings, let's see why picking the wrong comparator and perspective can steer your entire analysis off course. Imagine a $70 million contract disappearing because the wrong drug was used as a benchmark. That's the power of a bad comparator. When we talk about cost effectiveness, the comparator isn't just a footnote. It's the foundation of every number you see. A systematic review of 212 United States studies found that roughly 30% of published analyses chose a comparator that isn't the guideline-recommended standard of care. That isn't a tiny typo. It's a systemic flaw that has already cost the system $1.2 billion in downstream overpayments across just 5 major oncology drugs between 2019 and 2022. Take the CART cell therapy case. The startup modeled the new treatment against the old CHOP chemotherapy regimen, even though the National Comprehensive Cancer Network's 2023 guideline lists DA-EPOCH as the true standard. Using CHOP dropped the incremental cost-effectiveness ratio from $150,000 per quality-adjusted life year to a shocking $20,000 per quality-adjusted life year. That artificial win secured a $350 million price cap contract, which was later rescinded, wiping out an estimated $70 million in projected revenue. The lesson? A single outdated comparator can flip a model from unaffordable to golden ticket and back again. The problem isn't limited to drug choices. Perspective matters just as much. Switching from a payer-only view to a societal view can swing an incremental cost-effectiveness ratio by anywhere from -45% to +70%, with an average shift of 30%. In a state Medicaid evaluation of a new GLP-1 agonist, a payer-only analysis reported a ratio of $62,000 per quality-adjusted life year, leading to rejection. Once the analysis added indirect costs, productivity gains, and caregiver time, the ratio fell to $48,000 per quality-adjusted life year, and the drug entered the formulary, saving the system roughly $12 million in downstream complications. Even the biggest payers aren't immune. A Medicare Advantage plan double-counted a diabetes diagnosis in its risk adjustment algorithm, resulting in an $85 million overpayment for fiscal year 2021. The Government Accountability Office flagged this as a simple data entry error that could have been caught with an automated validation script, a loophole that many organizations still overlook. Why do these may happen so often? Only 38% of junior analysts say they feel very confident that they've selected the correct standard of care comparator. As Dr. Michael Drummond reminds us, a missing discount rate is the single most common error I see in graduate theses. It inflates benefits and misleads decision makers. The same principle applies to comparators. If the baseline isn't clinically relevant, every downstream calculation is skewed. So how do you avoid these costly pitfalls? Here's a quick cheat sheet you can start using today. First, verify the clinical guideline. Pull the latest NCCN, USPST, or disease-specific recommendation for the analysis year. Second, build a comparator checklist that confirms the comparator is guideline-approved, holds at least 10% market share, and uses current price data from the Red Book or CMS. Third, declare your perspective up front and list every cost category you'll include, whether you're taking a payer, societal, or mixed view. Fourth, run a scenario analysis by rerunning the model with an alternative, guideline-approved comparator, and with a different perspective to test robustness. And finally, document and version control the model with a clear date, version number, and what changed note, and store it in a shared, auditable repository. John H. Lee, a chief financial officer who runs a model audit checklist for more than 30 hospitals, says this 5-step process catches 85% of the myth that would otherwise hit the bottom line. And there's one more hidden safeguard that most analysts miss: a simple automated cross-check that flags any comparator whose price list is older than 12 months. Implementing that check can prevent the kind of telehealth overpayment that inflated quality-adjusted life years by 18% in a Midwest health system, costing insurers $150 million in unrealistic savings. We'll dive deeper into that automation trick in a moment, but first let's keep our focus on the bigger picture. Remember, a wrong comparator or an inappropriate perspective isn't just a methodological footnote. It's a financial lever that can move the needle by tens of millions or even billions across the healthcare system. Now that we know how a bad comparator can wreck a model, let's see why ignoring uncertainty can be an even bigger pitfall. Ignoring uncertainty isn't just a shortcut. It's a money leak that can drain billions from a healthcare system. Most junior analysts admit they skip probabilistic sensitivity analysis because they're pressed for time. 68% say they just don't have the bandwidth. Yet the data tell a different story. When a proper probabilistic sensitivity analysis is added, the probability that an intervention is cost-effective at a $100,000 per quality-adjusted life year threshold can swing by as much as 22% across published studies. That means a model that looks solid on paper could be wrong half the time. The fix is surprisingly simple. First, Give every uncertain input a statistical distribution: beta for utilities, gamma for costs, log normal for relative risks. Then run at least 1,000 Monte Carlo simulations. The International Society for Pharmacoeconomics and Outcomes Research Guidelines recommend this as the minimum for a stable cost-effectiveness acceptability curve. Using the free R package HEMOD, a complete probabilistic sensitivity analysis that once took 4 hours can now be scripted in under 30 minutes, a 90% time saving. Why does this matter in the real world? Consider the AI diagnostic startup that projected a 250% return on investment by assuming 100% adoption. A probabilistic sensitivity analysis that modeled adoption as a triangular distribution between 40% and 60% dropped the median return on investment to just over 50%, averting a $10 million loss for investors. Or look at the Midwest Health System's telehealth reimbursement model. A deterministic estimated $120 million in savings, but a probabilistic analysis with 2,000 iterations revealed only a 48% chance of exceeding $100 million, prompting a scaled-back pilot. Documentation is the other half of the equation. A Government Accountability Office audit found that 27% of Medicare Advantage payment errors stemmed from missing version control or undocumented assumptions, costing $2.4 billion in a single year. Teams that store their models on GitHub and follow a simple model audit checklist report no major undocumented errors 85% of the time, compared with just 38% for those that rely on ad hoc spreadsheets. By making uncertainty analysis routine and by documenting every assumption, version, and data source, you protect your organization from hidden leaks that could otherwise cost billions.